Dr. Michael Sughrue is one of the world's foremost researchers and practicing clinicians in the field of connectomics. He is a neurosurgeon, originally from Oklahoma. He attended medical school at Columbia and his neurosurgical residency training at UCSF. He practiced in Oklahoma, and he grew that program to be one of the top glioma programs in the country during his time there. Currently lives in sunny Sydney, Australia. He's lectured around the world on management of glioma and the use of connectomics, and he's performed over 3,000 brain tumor surgeries, and he's published over 250 peer-reviewed articles on the subject. And yeah, this really does give him a perspective that he'll be able to translate in today's course. So with that, I'll hand it off to Dr. Sughrue.
Hey, thanks everyone. Maybe the first CME course that I've ever taught from the Great Barrier Reef. So you guys are seeing a historical moment. What we're going to talk today about is trajectories. And this has a lot of overlap with the other course because the same things that make a good disconnection make a good trajectory. There are some differences, and this second part of the course accomplishes two things. We're going to talk about the differences, and then we're going to reinforce the really core concepts that overlap between the two. Let's dive into it. So as pointed out, we're working with software that I helped found a company about, and currently serve as Chief Medical Officer. So this is a slide from last time, and what you can see is that when we're talking about white matter anatomy, network anatomy, anything you're talking about, I think that what's oftentimes muddled the water a little bit is that we talk about it in terms of trajectories or surgeries, and it's important to keep straight what you're actually using the network anatomy for. And it really comes down to what is the challenge that you're going to encounter where you're going to tangle with the networks. So for example, if you're approaching that thing on the right, that's in the back of the thalamus, the thalamus is a fairly consistent structure. There's not a lot of variability to its anatomy. And so it's good to know those kind of things, but ultimately you're either taking this thing out or you're not. And where the networks, the variable portions of the brain anatomy live is on the way to the target. The cerebral anatomy is quite variable, particularly in the setting of pathology. And so where you're going to do a lot of the avoidable damage is on the way to the target. So going through a language network or the visual system to get to this thing, and you have to cut through something, as Roden has pointed out many years ago, it's impossible to make a plausible approach to the ventricular system that doesn't involve cutting neural tissue. So you're picking your poison. And in this case, what you're trying to do is pick a path that helps you get to the lesion. Now, not that the lesion by itself is very challenging and dangerous, but the difference is it's not variable. So it's the variability where connectivity-based technology is really important, because it's hard to know exactly where the language system is on your way there. We know the thalamus is dangerous, but it doesn't change very much. On the one on the left, you're tangling with the networks almost the entire operation. So instead of thinking about a trajectory, you're thinking about planes. And this basically, ultimately, whether or not you take the tumor from the inside out or you do it like I do it, where you start right on the boundary as early as you can, you're still disconnecting what's going on, what's staying. So these are two different ways that the same exact anatomy comes into the operation. And so it's important to think about, are you trying to do a trajectory or a disconnection? And sometimes you're trying to do a little bit of both. Okay, so what we've talked about for a while is that we're pretty good at not injuring motor, and we're pretty good at not injuring speech and language, okay? We have mapping, we have reasonable understanding of where these things are located in the human brain. And to not say that we always get the job done, but this is not necessarily where connectomics is going to make a big impact. In part because we can make a better map and this kind of thing, that's great. But where it really becomes very challenging to make improvements with the existing technology is when we start talking about cognitive networks, because these networks are diffuse, they're often very complicated, there are different parts of the brain, the anatomy isn't consistent between individuals, and these kind of things really make it hard for us to envision how do we do surgery on people where they go on and have the best cognitive outcome they can given the circumstances. Ideally, that they go back to work and live a normal life. That's what we're aiming for, whenever that's possible. So what we started talking about a while back is how do we reduce the cognitive footprint? And this is the same for trajectories as for disconnections. So what can we do now that's simple, not really that theoretical, it aligns exactly with what everything else we understand, and don't cut through the middle of large-scale brain networks. We know that with the motor system, if you disconnect the SMA from its targets, you get SMA syndrome. You cut the corticospinal tract from the spinal cord, you get a hemiplegia. With language system, if you destroy the interconnections of the language system, you get language disturbances. This is not something that most people will have a hard time buying into. The real issue is we just need to know the anatomy of networks. And when you're talking about trajectories, this means don't cut through the middle of large-scale brain networks, and also don't enter, if possible, through the middle of an epicenter of a large-scale brain network. So don't use that as your entry point. Now, notice I say whenever possible. So if you go, and I remember the first time I ever attended a white matter course, I was really excited to see how people applied it. And what they basically just said was, well, this is why I go supracerebellar transtentorial to get to the medial temporal lobe, because this white matter is important. And that's great if you can do things like that. But reality is that's not always possible. Sometimes the stuff's in it. So, there's no cute way to do this case on the left. This is not the case that people tend to show at these kind of things, because in reality, what you're trying to do is do a damage minimization approach where you're trying to do as little damage as possible, given the fact that a tragedy has happened to this patient. And so while it's nice to do these nice approaches, we talk about it in courses and we, do some really interesting stuff with that. At the end of the day, these are the cases that are less glamorous, but a lot more common. And so if we ultimately, it's whenever possible, don't cut to the middle of large scale brain networks. We'll talk a little bit about the full brain ramifications of an action. And of course, the future is eventually that we start thinking about things in terms of individual circuits, personalizing it, determining individual differences, and then even considering, can we change the connectome with TMS guidance? So number 3 and 4 are kind of outside the scope of a course like this, but these are what we think is the path forward. So I'm going to outline a few trajectory related network principles. And this is actually new. I've never phrased it this way before. But I think it's a good way. It's kind of how I thought about it for years. So the first is this: we spend a lot of times talking about white matter, and particularly from the SSG, you probably have some concern about white matter as well. But we care about white matter because we care about function. So you have to cut some fibers. I mean, there's no, to get that tumor on the right, you have to cut something, right? So you're not picking, we don't want to have this mythological view of white matter where we want to preserve it in all cases. It's silly. Of course you're cutting some white matter. What you're trying to do is not cut the wrong white matter. And you want to not cut the wrong white matter that underlies a function. So that's what the patient cares about. They don't say, well, my eyeball feels great. They say, they tell you what actually they notice. And networks are function. So for the most part, to the extent that we care about white matter, we care about the white matter that's linking up networks. Now, it turns out there's a lot of correspondence between this. So for example, if you cut to the middle of the arc of fasciculus, you take down a lot of networks in the process. But the bottom line is, networks are the fundamental unit of human brain function to the best of our understanding. And so we should preserve it, because that's, that's what we're ultimately trying to accomplish for the patient. The second is that for a long time, and when I was trained, in general, everyone thought, take the shortest path because you cut less fibers. And the answer is that, of course, think about this as a thought experiment. Would you rather cut through 2 millimeters of the central tegmentum of the brainstem, or 2 centimeters of the right frontal pole? And the answer everyone knows is obviously the second one is safer. So unfortunately, in the brain, you don't have an egalitarian system. There are areas that are definitely more important than others. And so sometimes we have to break the rule of the shortest path. Now, having said that, sometimes you also have to use common sense. So if you have a tiny, tiny rim, of brain over this thing, that even if that rim is the motor cortex, it's still probably better to just go through it, right? And ultimately, at the end of the day, be careful, but be really, thoughtful about that kind of thing, because there are times that that tiny little rim is a lot more important than you think. And so, of course, we all have encountered these things where we thought, oh, that was a safe approach, and it turns out it wasn't. The next one, and this is probably new to people, we'll talk about this. Whenever possible, don't go through the middle of a hub. And we'll talk about what hubs are, ideas on how to find it, and then, kind of our thought process in the future on how we can make this a clinically achievable goal. And then the final one, and the more I've done surgery, the more I really become militant about this, is whenever possible, work down. Working back on yourself, as in the patient's head's here and you're working back on yourself, is almost always a less desirable approach. Because no matter how you do it, even if you position the head the right way, even if you tip the head down, if at all possible, it's inferior to working straight up and down. The brain gets in the way, you have to work at angles, and if you're uncomfortable, there's just no way you're doing your best surgery if you're standing on one foot and leaning over the patient's shoulder, right? And it's just that's what the kind of things you have to do to get to these things. And that is sometimes unavoidable. But whenever possible, if you have a tie between 2 approaches and one of them requires you to work back on yourself or at a weird angle or an unfamiliar angle, always pick the other one, even if it seems like it's slightly longer. Okay, so let's go through these principles a little bit. So shorter isn't always better. And so this is the language system. And again, going through the middle of Broca's area, even if it's, a shorter path, is generally inferior to going a longer path through the ear. This is kind of the principle that people who are focused on ICH have been talking about for a while, is that sometimes going through locally connected areas is better than going through shorter paths through distantly connected areas. And now I think what we want to talk about is in this situation, why is going to a white matter bundle worse? And the reason is, it's the whole concept of the en passage tracks. So if I'm basically going through this frontal area, most things are connected to their immediate neighbors. And so if you're cutting through this cortex, you've already done the disconnection underneath it. Whereas if you cut through this, you may be getting things that are just bystanders, and you're also just doing it in a lot more dense area. So there's a lot more areas that are connected to that couple of millimeters. So it's not always possible. And if it's a really, really short trajectory, sometimes it really is the best thing, because the other angle also takes you through the trajectory on the other side. So it doesn't mean never, ever do that. It just means really think about this. And just because we were taught that, oh, it's always best to do the shortest thing and the most elegant back behind the sulcus thing because it looks cool, that's not really necessarily always the most effective thing. Sometimes just the good old fashioned simple infantry approach is better. Another one to think about is this. So, training with Michael Lawton, he always emphasized going through sulci. And I know a lot of people, we have this, and it's generally a good approach because it's a simple way to shorten the distance. And so especially if you're familiar with things like transsulcal approaches or tube surgery and things like this, it can often be a great way to minimize the footprint. But again, that is like everything, that isn't always true. So a sulcus is equally filled, the bottom of the sulcus is equal cortex to the gyrus. The brain doesn't view this as a difference. So while these can often be useful, there are some sulci that this is not true in. So this is, for example, the dorsal tension network. You can see that it has 3 nodes. One is the frontal eye field, which is in the precentral sulcus, where the middle frontal gyrus it comes up to the motor cortex. But also, if you see those guys who are IP, they're also sitting in the interparietal sulcus. And so if you're basically, putting your port down those specific sulci, you're going through the middle of the network, right? I mean, you're taking through the dorsal tension network, which has significant cognitive consequences. In fact, it's probably the case, based on the evidence, that the more of this network you lose, the more your IQ drops after a stroke. And so it's not a very big network, but you probably don't want to be in the front part of that sulcus. And so, again, like everything, you want to basically utilize many pieces of information to make good decisions. And so you would rather, in this case, take a longer trajectory through the superior parietal lobule than go through the anterior interparietal sulcus. It's less damaging. You're not going through the core of the network than the superior parietal lobule. So if you look at the Human Connectome project, one of the things that really struck me when I first saw this 5 years ago, and still strikes me, is that if you look at the map on the left and the map on the right. So the map on the right is the folded version of the map on the left. So what the software does in these kind of things in order to display it is it actually unfolds the sulci so that it turns the brain into kind of a ball. And this is the not completely unfolded, but mostly unfolded brain. And so what you can see is that there are areas, for example, that are tucked under the operculum that are different than the outer surface. But more importantly, if you look kind of at roughly about 6 o'clock here in the middle of the screen, you see these STS regions. These are completely tucked into the superior temporal sulcus. And this is basically Wernicke's area. So if you look at it, you can, again, number one, that the brain views sulci and gyri equally, and the floor of a sulcus is also brain, and it may be important brain. Sometimes it is, sometimes it's not. So we're going to talk a little bit at the course about things that sit in sulci that you might think about not going through. Now, having said that, it's always if possible. So remember that you cannot be totally dogmatic with this kind of stuff and say, well, you can never do this, you can never do this. Sometimes you have a horrible cancer, it's in all of these areas, and to back out and let the cancer take the patient is just kind of cowardly. What we're trying to do is to minimize the damage given the circumstances. So there may be a situation that the interparietal sulcus is the absolute best and only angle. It may be the case that the superior temporal sulcus is the best angle to this thing, but you need to balance it and not just assume that this is like a cistern where there's no consequences for navigating down it. It's not always possible to utilize cerebrovascular type skull base approach thinking in the cerebrum. The brain is not organized that way. And so part of what we're trying to do here and today is to really give you guys the tools so that you can understand when is the brain really telling us that this is not a good idea. So for example, if you were to take this approach or down the central sulcus, or here right in the precentral sulcus or the middle frontal gyrus, or go down the superior temporal sulcus, or maybe go right through this area here. The answer is that in some of these cases, you would rather be on the gyrus, even if it's slightly longer. So for example, if you're another angle to think is if you're in the if the interparietal sulcus is the best approach to your lesion, maybe you want to start back here where it's not the middle of the default the dorsal tension network. And those little distinctions, while they're not necessarily obvious and intuitive, these are things that what Connectomics has taught us. These are the differences between the patients who are totally fine a lot of times and probably the patients who don't do as well. And we may not necessarily always notice this one immediately after surgery, so we don't get this lesson. But when the patient's family comes back and tells you everything that's wrong with them, and you say, well, surgery's hard and all this stuff, this may be what we're doing wrong. And it takes a lot longer for us to learn this. Otherwise, this would have been standard teaching since the 30s. And it just hasn't because it's a lot more subtle. Now, again, I can't stress this enough. I would rather do a less glamorous approach that let me work like I am on the right than working back at myself. So if you look here, if that little bump at the bottom is the chin in this diagram. And so what happens is that if the patient was a decapitated cadaver head, this would be irrelevant. Even then, it would still be slightly better to work like on the right. But the patient has a body, and And if you're, as long as you're trying to think about how to improve outcome, it's generally a good idea to keep the head and body connected. So given that there's a body there, you have to, if you're working on that angle on the left, you're going to be working back on yourself. And this, nobody is good like this. This is how we operate. And so sometimes the one on the left is unavoidable. If you're trying to get to the, up in the atrium, the lateral ventricle after a temporal lobectomy, you have to do it, right? There's no way around it. But you can come up with some very, very interesting and elegant approaches that require you to work at difficult angles. And perhaps there are people in the world who can pull this surgery off on a regular basis. I personally never found myself to be one of them. I could do the surgery. I was never as happy with my results as when I actually just looked at the networks, avoided cutting through them if possible, and did an operation that I was totally comfortable. Those are the operations where I got very good resections, was happy with what I did. And so I think this is often a caution to younger surgeons, and I can say that I've fallen into this trap too, is that, you learn cerebrovascular, you learn skull base, and, I've done lots of skull base in my life, and you learn these kind of nice approaches to enter the angular gyrus, or the, the gyrus rectus, or the medial temporal lobe, through these very, acute angles. And sometimes that's great for a nice located calf mound where the boundaries are clear, the lesion is small. These kind of things can be really useful for patients, but you really should always think about sometimes cutting a little bit of brain in an area that's safe gets you a better angle and a better result. And so often taking, a popular one is the supracerebellar transitorial approach that I mentioned earlier. It's a nice approach, good angle, and maybe in some very small lesions, it's a good way to do the lesion to avoid complications of getting to the brain. But what happens is, if you're doing an approach that you don't do very often, it's very easy to become disoriented. These are not the angles you're used to. The angles are often awkward. Again, the direct approach and working straight up and down is always better. And when you don't know exactly where things are going, it's often hard to know, okay, what is the angle here at this thing if I'm not doing this every day? And inevitably there are blind spots, right? Because you're working at an angle that oftentimes is compromised. And so brain surgery is hard, and we shouldn't make it harder by taking, very complex approaches to things. So while I'm not saying don't ever do that, what I'm saying is, in some cases, it's better to just take a direct angle that's less glamorous and use the network anatomy to make sure that as much as possible, we're not going through bad parts of the brain. Because if you have a nice clean direct angle working straight up and down, most people are better surgeons doing that than trying to pull off some circus maneuver to avoid cutting through the brain. It's, again, the brain does tolerate being cut into. It doesn't tolerate certain maneuvers. And so a lot of the reason that we do those kind of things is we think, well, I've had this approach before, it went badly, I had this complication, and so I don't know what's the problem, but I'm just going to not cut through the brain. Well, that's the same thing as saying, well, one time I was felt uncomfortable taking down the temporalis muscle, so I'm not going to actually get enough exposure to the right pterional. And the reality is, the better approach is to really have full knowledge and pick the best approach for that situation and that anatomy in that patient. And sometimes that really is doing these fancy things. I've done plenty of, contralateral transcallosal things that for the right situation, but you shouldn't force it. And that's what I'm trying to get at here. So I mentioned hubs, and what are hubs and why should we avoid them? So networks are a useful tool. It's easy to understand. Don't cut through the middle of networks. And when you're talking about disconnections, a lot of times, again, you're making a different discussion of the, you're just trying to spare whatever network you can. Sometimes you can't spare them. But trajectory is a little different because the entry point is a key part of the operation, right? So if I'm removing a part of brain this big, this nuance of whether it's here or here is not really relevant. But when we start talking about, okay, well, I found a cortical entry point, this trajectory misses a network. how do I, is that really the right thing? And there are gyri and sulci, there are parcellations in these areas that oftentimes hit over their weight. So when we know that we can move the trajectory 2 millimeters or pick a sulcus instead of a gyrus or vice versa to avoid some of these things, we can often even further reduce the cognitive footprint in a way that isn't really often possible with disconnection type surgeries. And why is it important, right? So a lot of brain functions are uni-network. So if you talk about who does speaking, it's the language system pretty clean. If you want to talk about who does, episodic memory, it's the default mode network. There you go. But we start talking about things like math and things that determine whether this patient can go work a job like the kind of job we're doing, where it requires fluid intelligence and minimum cognitive footprint. Otherwise, even though you might look fine, you can't do that job anymore. Then we have to recognize that how the brain does some of these functions involves certain parts of the network, different networks talking to each other. And so what you're looking at when you look here at mathematics is this multi-network problem. So the network model can get us a long way, a lot better than we're doing now. So obviously destroying the dorsal attention default mode network is going to do a lot more damage than any of these other subtle things. But one of the thoughts is that can you basically utilize additional knowledge to avoid bad entry points? And if you look at this, one of the ways that people handle these extraordinarily complex inter-network communication issues is a technique called graph theory. And what graph theory basically is a branch of mathematics. And it turns out it was kind of an esoteric branch of mathematics until about 1998, when a very seminal Nature paper came out that showed that no matter what network, what complex system in the world you're talking about, they have the same graphs. And so you can use the same techniques for the internet to study the brain, and it all made sense, and the mathematics made sense. So what graph theory does is it looks at the whole network and studies different features of how information flows in that network. And it's a huge area, but I'll kind of talk about the simplest one. So how do we make the brain into a graph? We take the DTI, we parcellate it, and then we calculate how many fibers are going between every area and every other area. So you get this giant mathematical equation, which represents the connectivity of the brain. And so you've simplified it from something that's intractable to something that you can do experiments on. And what the term hub means is a hub is a part of the brain that is highly connected. That's all it means. So it makes sense. It's like Grand Central Station has more train lines going out of it than the train station at Columbia Presbyterian at 168th and Broadway that I used to take for years, versus something that's way out in the Bronx. So that can be measured. And needless to say that a complete shutdown of Grand Central Station has a much more of an impact of the New York subway system than one station in the Bronx going down. And the brain behaves the same way. So we can measure this different ways, but in short, that little shaded node on the right is more of a hub than the one on the left. And we know that because it's connected to a lot of important guys and a lot of people who are also very connected. Whereas this guy on the left, even though it has the same number of connections or the same degree, has lower centrality because it's the guys that it's connected to aren't very connected. This term PageRank was actually Google's initial intellectual property for their search engine. They do it differently now, obviously, but it was basically how do you measure centrality in the system? And so we measured centrality in the brain, and we're not the first people to do this. A lot of people came before us. What we said was we're surgeons and we want to know what does this mean in the real world? Because otherwise there's no reason to study theory if we can't apply it. So the first question was, who are the hubs of the brain? And it turns out if you are grading an AVM, even if you don't know who all these parcellations are off the top of your head, these guys here in red get you the point for eloquence. So these are the Broca's area, the visual cortex, the motor cortex, et cetera, right? But not surprisingly, hubs are eloquent areas. These guys too should get you the point, but we didn't know what they were and we didn't have a name for it. So these had different types of eloquence, but we now know, I can tell you what neurological problems you probably get from these things. And the bottom line is they're hubs of other networks that we just weren't talking about. So the truth be told, the areas that we call eloquent are hubs. And we know that hubs have special properties. They have different genetic expression. They express different genes. They have, they use more energy. They're more susceptible to developing Alzheimer's, and they play a disproportionate role in how the brain works. All right. So losing your hubs is bad. And so we know for years and years and years that we shouldn't cut through the middle of hubs. We just call them eloquent areas. Now, this is a paper we published last year, and what we were asking was, how often do people have hubs in parts of the brain that other people don't? So, you know, you don't need graph theory to say don't cut through the motor cortex, where you kind of know that. But what about, are there sometimes people who have individual hubs? And the answer is 7% of the time. So this is it, without going too much into detail, this is about 400 something people, I forget the exact number, that we ran through a machine learning algorithm and said, how often are there hubs in places that we don't expect? So for example, if you look at this area A10P, this is at the frontal pole. Okay, so pretty much as safe as it gets. And in the color is basically saying for that person, how much, each one of these is a different person, each column is a different person. And what you can see in red here is that in this one person, and only this one person, this is the 10th ranked hub of the human brain. So it's up there with the Broca's area and the brainstem of the top hitters. Now, we don't know that these are the people that actually do worse if you do operate in the frontal pole. These kind of patients who we do take out a calf mal, and they're telling, everyone's telling us, they're telling us all the problems they're having going back to work, or the emotional problems. But it certainly seems that this is quite possible. And so we hope that in the future we'll actually be able to measure hubs and have that kind of personal integration where we sit down and think about this before we put, decide that A10P is, oh, it's the frontal pole, it's totally safe. And it may not be safe in that one person, everyone else it is. And we all know that there's a variability of outcomes that sometimes we don't explain very well. So what we're going to do is, and part of the reason we did this course in 2 parts is there's different issues. And the other reason is because we want to really hammer home the anatomy of the brain networks. Because if there's one thing we want you to get out of this course, it's at the end of this is like normal anatomy that we talk about. Because from a neuroscientific standpoint, these are things that are really not controversial at this point. There's, in many cases, thousands of papers on these networks, and we know what they're doing. So we have a pretty good idea that destroying them, we're often likely to hurt that function. There may be people who tolerate that, but again, that's a clinical question that we determine later, not something that I would recommend doing now. So we're going to try to really get down the networks. This is going to be almost a complete repeat of last week, but I think most people probably will agree that you benefit from this because repetition is how we learn. So what we're talking about in network, what we're talking about, just to remind everyone who, or refresh people who were, or bring people up to speed who weren't here last week, what we have is different parts of the brain have a bold signal activation. They're activating at different time points. And you can study this with correlation. And areas that are networks, what we call a network, are areas that have highly correlated bold signal, meaning that one is firing, the other one tends to be firing. Now, there's almost no part of the brain that's perfectly in sync with any other part of the brain. And we wouldn't want it to be, because ultimately, sometimes they leave their network and work with another network to do a different function. But what it means is that they tend to be firing most of the time as a unit, probably because they're doing common tasks together. And usually, in fact, I can only think of one exception that this is not true. They're directly connected by a physical white matter connection. So cortical connections are enough to explain how most networks are networks. And so in this classic paper from about 10 years ago, a group at Harvard, headed by Randy Buckner, did this to the whole brain. They said, everyone, we're going to divide the brain into 7 networks. They have a reason why they picked 7, because it was the natural cut point in the data. And let's sit down and every part of the brain gets grouped with its neighbor, with its closest network neighbor. Who does its bold signal closest to? And you basically get a map that looks like this. So the sensory motor system is in blue. That's not surprising. It fires as a unit. So the sensory cortex is closer to the motor cortex than anybody else. The visual system works as kind of a unit, not shocking. The limbic system, that includes the orbitofrontal cortex, parts of the inferior medial frontal lobe, like the subcallosal regions, and parts of the temporal pole work as a unit. Okay, so that shouldn't be too shocking to us. But in orange, you have the central executive network, which you can see has multiple parts. The default mode network in red, salience in pink, and dorsal tension in green. Those are the 7 main axes of the brain. Again, what we're doing is ultimately comparing both signals. Now, if you get more fine-grained, you can continue to subdivide these. And this is where a lot of, if you try to DIY it yourself and learn this by reading papers or whatever, the literature is pretty dense, and it's not entirely made clear to the amateur like myself when I was learning this exactly what was going on. So what you can then do is you can continue to subdivide the brain. You can subdivide the brain to 360 areas. What the HCP found is these get down to the unit of function. It's hard to subdivide below that. That's what the parcellations are. So that, it's hard to subdivide this in a rational way. I mean, you could get it down to voxels, but the neighboring voxels of a parcellation are kind of so close that it's not worth making that distinction any further. This is why this is an almost 400-page paper of why these are the areas. And think about this in terms of an atom. It's possible to subdivide this, but for practical purposes, it's hard to justify subdividing it further unless you want to get into studying bosons and things like that. So, but the bottom line is, usually from a practical standpoint, clinically, it's often really not necessary to get the distinctions below about 17 networks. And this is kind of how they divide up if you decide to make a more stringent threshold. So there's a couple networks that subdivide pretty neatly. The default mode network includes the language system. It includes a core, which is what when we say the DMN, usually you're referring to the core and not this whole global network. So the language is closer to the DMN than it is to the central executive network, but it's closer to itself than it is to the core, if you get down to it. There's a portion in the parahippocampal gyrus. This is probably the memory circuit of Pepez, and I'll show you where that is. And once you see it, you kind of don't unsee it, but it's pretty clear what it's doing now. And the SCG is probably the auditory system, auditory network. The central executive network can subdivide. I don't have as good of a narrative on this one. I haven't dug in and spent the time to figure all these areas out. So I mainly focus on the core. But notice that there are other areas that are roughly affiliated with the CN. The Salience Network is its own beast. It doesn't subdivide really unless you force it to. The Dorsal Tension Network and Limbic System are the same. The sensory motor system can be subdivided into an S2 region, which is the secondary sensory area, and then all the primary areas. And the visual system subdivides it to the ventral and dorsal streams. That's the what and where pathway, the primary regions, which is V1 to V4. It's on the medial occipital lobe, and a very complex set of lateral systems, which could almost be its own symposium if someone wanted to go over it. So this is kind of what it looks like. And so you can see that, for example, the pink in the Salience Network is the exact same areas, doesn't subdivide, same with the green. But the language system here in red is now separate from the global DMN, because when you subdivide it, it's its own system. Notice that this is not the same as speech areas, right? Speech and language are two different things. Speech is the physical production of sounds with the mouth, tongue, larynx, and pharynx, and language is the cognitive aspects of that. The way I describe that is think about the term apraxia versus paralysis. So, paralysis is the inability to do the motor function, and apraxia is a deficit of the cognitive control of motor function for using tools, for example. And so that's kind of a distinction to think about with language and speech. Speech is paralysis of the language of the speaking areas, and language is a failure of the cognitive control. And so when we start thinking about mapping, for the most part, we're doing more speech mapping. There's some exceptions. You can do anomia, it's pretty reliable. You can probably study reading, but for the most part, you're not necessarily studying things like verbal memory. It doesn't really map very well that we've seen. And otherwise we would, we wouldn't be able to take out the temporal pole in people and claim that there's no consequences to it. So we have to realize that we're studying speech and not language, and they're related, but they're not the same thing. And so the language system pulls out from the rest of the main network. You can see here in the motor system, also notice that the arm and leg cortex breaks off from the face cortex. And notice that the face cortex also has some portions in the head shoulder gyrus. So not surprisingly, and we've been messing around with machine learning, it's probably something we'll be bringing into Connectome at some point in the near future. The machine learning is very good at telling this from this. It's pretty impressive. They really are different units at the end of the day. So, and of course, there are some networks that we call networks that are actually mixtures of networks. And these are really the multiple demanded ventral tension that I'll talk about. They serve useful purposes as intellectual constructs because they link to functions, but they're really a mixture of these networks. It's not based on bold signal, it's based on some other justification. So when we decide to make decisions about networks, the first thing about it is this. Obviously, we have to cut the brain somewhere. And if you have too much information, you can basically make it impossible, right? If you say everything is eloquent, well, of course, then you can't do brain surgery, so we're out of business. But what we have to think about is, okay, don't cut through the core of the network, the really central areas. And the second is, sometimes you shouldn't try to save it at all. So if you're talking about a cancer that's invading the network and it's tucked in there, yeah, you want to try to save it if you can, but sometimes you can't. And maybe this will be eventually, something that we come back to, like the facial nerve and acoustic neuroma, where first we don't have the techniques, then people figure out the techniques to save the facial nerve. And then we have debates about the value of doing this, gross total versus subtotal in these kind of situations. But, in this case, we just invented the nerve stimulator. So it's now possible to have this discussion. But for right now, it may be in some situations that, unlike acoustic neuroma, this is cancer and it's going to take the nerve out at some point. And so you have to ask, am I really getting a good trade for, in many cases, leaving pieces of tumor? And sometimes if you're talking about some lesions, the answer is yes. If you're talking about some lesions, particularly high-grade gliomas, the answer is probably no. This is a clinical question, and honestly, there's a massive room for research publications on this. So for many people who are younger who are looking for things to write up, this is kind of like the new skull-based approaches of our generation, which is getting into the nitty-gritty details of what do we do with all the implications of what we found anatomically. So quickly run through the networks. If you were on the course last week, you're probably familiar with this, but again, we'll repeat it again. This is the core of the default mode network. It has three components: anterior cingulate, posterior cingulate, and lateral parietal. If you had to describe what it's doing, I kind of describe it as the closest thing we have to the soul. It's the part where internal thinking is going on. It's the part when you imagine things, when you think about episodic memory, and it's just important for numerous cognitive processes. So it's not surprising that when it doesn't work, it ultimately causes a lot of mental illness. And so it is hard to find a mental illness when the default mode network has been shown to be completely normal in all patients. This isn't the way it works. It's usually abnormal in certain ways, but it's very complicated. Having said that, where this really tends to come into the discussion is things near the midline around the cingulate gyrus. This is when you really have to start having DMN considerations into it. And again, in the neuroscientific literature, when I talk to neuroscientists and describe that neurosurgeons, we didn't even want to talk about the DMN, and I didn't know about this, and when I finished my training, and then we figured this out, and all of a sudden we stopped having patients who had a lot of serious problems. They're shocked that people are cutting across this, because they're like, it's like, if you're telling a neurosurgeon, oh yeah, no one was paying attention to the corticospinal tract. It's surprising to them, because for them, this is really a non-controversial question. And so I think we have to have a lot of discussion about, whenever possible, we should try to preserve this network. It's a very important part of the brain. In its vicinity, it controls how a lot of parts of the brain work. In fact, the posterior cingulate is more strongly correlated with more parts of the brain than almost anything else. And it basically, one of the things that it does is controls the language system. Now, again, language and speech are interlinked. So for example, this area 55B is kind of a little bit of both. It's a laryngomotor cortex. I'll just say that the evidence is becoming more clear that this is an area of the brain that we should respect, even though it's very small. As well, if you look at the temporal lobe, the parietal lobe, it's a lot more complicated than the simple Broca-Wernicke model that many of us have been operating under. Notice that also, when we talk about speech, for example, speech has a motor planning area. This is an area called 6R. It's in the lateral frontal montage in Connectome, and it shows you how the speech system and 55B interact with the language system in multiple areas. But also there's this area that we call the accessory language system. We published a paper in neurosurgery on this a couple of weeks ago. And what it basically is how the Wernicke system communicates with the temporal pole. So if you go back, and I want to show you this, that accessory language system is this little red strip right here. Okay. So this is kind of how verbal, there's a comparison between the hippocampus, this system that connects to Wernicke's area, and the visual system that's happening that helps retrieve and name things and determine what word you're trying to say. And of course, if you look here, not surprisingly, it connects to Broca's area. Now, if you look at this little intervening guy here, this is that area 6R. And it's important to know that if we actually look at the anatomic Broca's area, this is a multiple network component, none of which are actually motor. So what a lot of the motor planning areas really are is when a bunch of different networks come together around the motor system. Now, getting into the other components in the extended default mode network, the auditory network has its own system and has its own connections to Broca's area. They're independent of the rest of the Wernicke areas. And you see the auditory system is quite complex, but as we know, some of it is bilaterally innervated. And also you have this area, the PHG area, which isn't very big. It's that isthmus of the cingulate gyrus down into the perimecampal gyrus. And it doesn't look like much, but the evidence that's come out over the last year, and there's been about 4 really good papers that have clearly shown this, is that this network is where episodic memory happens. So when people have this quote short-term memory and they don't remember things that happened yesterday, this is what they're losing. So, we've learned the peptide circuit, the anterior thalamic connection to the cingulate, and the cingulum loops around. But what really the issue really comes down to is keeping this thing together is what really prevents those kind of memory issues. So it's basically anatomically equivalent of cutting the fornix. Moving to the Salience Network. The Salience Network is a middle cingulate to anterior insula connection. That's how it works. There are other components of it. It's not very old. It was really first elaborated in 2008. So this is relatively new, but the evidence is piling up that this does a lot of important things. And so the way to think about how the Salience Network really is the insula, particularly the upper boundaries of the insula. There, as I pointed out, there are these areas of the operculum that are doing something different than the outer surface. So the undersurface of Broca's area, area 44, is a different region that's part of a different network. It's actually part of the Salience Network. And you can see here, that's that area FOP4. And those little undersurface opercular regions, many of them are doing things like interoception. And you think about why do people who have mental illness also have all these somatic complaints? It's because these areas are functionally abnormal in these people. And not surprisingly, that's the Salience Network is part of that. And so the cingulate gyrus, obviously on the medial side, it involves emotional and cognitive awareness. And these two things are linked together. So think about this as the 2 ways that something can need to jump to the top of your consciousness. from the inside or from the outside. And that's the theory that's been put forward on this. So we know that the Salience Network, even though it's relatively new and all this stuff, punches significantly above its weight as far as importance. So, for example, increasingly, I'm coming to believe that when we talk about SMA syndrome, we're really talking about the Salience Network as much as we're talking about motor. So that area sketched right there on the upper right part of this panel is also part of the anatomic SMA. As well, it's been shown that people who have chronic pain syndromes like fibromyalgia, this is actually one of the culprits. This network is overactive, means that they're too salient to events. We all know these kind of patients who aren't necessarily delusional as much as they're too sensitive to stimuli. And it's the network that's most fundamentally abnormal in depression. In fact, all the TMS targets that are FDA approved for depression involve targeting components of the Salience Network. So bottom line is much more important than we give it credit for. And the Central Executive Network is a frontal polar region, a supramarginal gyrus region called PFM, and this area called 8C, okay? And 8C we'll talk about a little bit today. And so 8C is kind of in the premotor region. It's part of Broadband Area 8. If you look here, with the exception of PFM, all these are Broadband areas that have been subdivided by the HCP. That's how you learn these things. And so the CEN does executive function. And it's actually the network that continues to develop most from age 10 to 30. So it's kind of the adult network. Now, why is that? Like, why is it specifically that network that helps make you a mature adult? And of course, we don't know for sure. But what we do know is this. There are networks in the brain that we best thought of as control networks. And what they do is they tell the rest of the brain what to be doing. How do you allocate resources? So for example, the visual system depends on parts of the executive network and some other networks to determine how does it interpret and process information. Those are top-down regulation. And of course, that's a big portion of what the IFOF is doing, is linking the visual system up to the executive areas. So now, what the executive network CEN basically is thought to do is that there are configurations of the brain that are energetically difficult to obtain. It actually requires areas of the brain to be firing in ways that they don't normally do. And that may be for a very specific cognitive task. And so what happens is the CEN's job is to force the brain into those very difficult to achieve states, which as it matures, it lets you do different types of parallel processing or different types of thinking. And this allows you to get the brain to work in ways that it didn't do before. The DMN does not seem to do that in the same way. And so the bottom line is, as you begin to get your brain into difficult configurations, you can hypothesize about things that you were thinking about before. And this is called maturity. This is adolescence. That's a very novel theory, but there's pretty good data that's behind it. And certainly from the mathematics, actually makes sense for that being possibly true. So dorsal tension network, it's an older network. And the best way to know that it's older is the closer you are to the motor cortex, the older you are in phylogenetic development. That makes sense because motor was probably necessary before executive function and evolution. We also know that the further you go from the motor cortex, the more individually specific you are. So if you look in the genetics of evolution of the brain, a lot of what they did was they made the brain flexible. They made the wiring diagram flexible. So if you look at turtles, the wiring, even at the microcircuitry level, is largely inflexible. And as we evolved, we began to make the wiring pattern more flexible. That allowed us to achieve individual solutions to problems that may not have been planned in evolution. And ultimately, if you look at the areas that are most open to flexibility, they also are the ones where the genes that are make the difference between humans and chimpanzees, that's where those genes are expressed, which is the frontal, prefrontal cortex, mainly the frontal pole, and the supramarginal gyrus. So this didn't get those genes. It's a pretty older area. It's designed for focusing attention. You can see that if you think about this, it actually makes complete sense of why the three parts are in there. So the frontal eye field is obviously moves the eyes. The intraparietal sulcus, the IP regions, are what they keep as a grid of where everything is located in the world from a multimodal sensory perspective. So it integrates, somatic sensory function, visual function, auditory information into a single world. And these lateral visual areas are part of higher level visual processing. So it makes sense that if you need to focus your eyes on something, this keeps track of where everything is. This tells you what moves the eye, and this is making a visual map that these guys use for that purpose. So the dorsal tension network makes pretty good sense. It's actually a very thin track. It's not a very big network, but it punches above its weight also. And notice that the motor cortex and sensory cortex are right back here. Now, when we start talking about the sensory motor network, you can see that the corticospinal tract is probably familiar to everyone. There's a couple of things that I can add to this. So the first is that, and this is something that just dawned on me one day when I was a resident when we were doing very aggressive glioma surgeries in this area, and thinking, well, where's the boundary? And I hypothesized, well, what happened if you just had the motor cortex skeletized on both sides? Well, of course, you're paralyzed, right? And if you think about that, that highlights the fact that this is a system and you need other inputs in order for it to work. Now, we don't know the minimum core. We know we can go pretty far and still initiate action, but we really have to think that in order to maintain motor function, you have to have something talking to the motor cortex. And these motor planning areas seem like a pretty good place for it. It's also important to know that there's a huge amount of bilateral mid-callosal innervation. So these areas talk to each other extensively, which isn't shocking, but what it is clinically important. So if you, for example, if you cause an SMA syndrome and you also cut the connection from the other side, it's hard to see how that could possibly improve. Because if you don't have something to initiate motor on the left side and no information is coming from the right side, how is that going to get better? And the answer is it tends not to. So there's actually some tracks in here, one of which we call the cross-frontal aslant tract, which are necessary to do this. So when you're dealing with tumors that really are as bad as you can imagine in these systems, there already is neurological morbidity for this. At the minimum, you have to think, how is the connection going to come from the other side? If you don't do that, then you can make a bad problem permanent. And that's again comes from personal experience early in my career where I learned not to do that. The visual system is interesting. It has multiple components. You can see the primary system is very big. It's on the medial hemisphere. We kind of know that. But you also have the ventral stream. This is the what pathway. This is the area that's talking to the temporal pole in addition to that accessory language area. The dorsal stream, which is the where pathway. Interestingly, there are a lot more hubs in the dorsal stream than are in the ventral stream. So I thought that was interesting. The ventral stream has actually its own connections to the auditory cortex. Also interesting why the brain has an entire bundle dedicated to connecting those two areas. I don't have an explanation for that right now. And the lateral system is a higher order visual area. And interestingly, it's pretty poorly interconnected. It kind of lives in its own world and has 2 points of exit. And of course, finally, the limbic system has the familiar characters, but it's also important to know that the orbital frontal cortex, the subcallosal cingulate, that's this thing in blue, this was the target in the clinical trial for DBS for depression. And so that's an area called 25, it's a parcellation, and it sits on the genu and rostrum of the corpus callosum in the cingulate gyrus. And so you can see the limbic system is a little more complicated than we thought. And there's parts of the cortex, there are cortical regions that involved in it. So it isn't just the hippocampus and amygdala. Looking at the combined networks, the ventral tension network is an identifiable subcomponent that's a mixture of different networks on the right side. And it not immediately clear if it's the neglect network. It makes sense But I think that the bigger issue is that the data seems to be lining up that at least the right SLF is the connecting the areas involved in neglect. And the ventral tension network is a very good candidate. I mean, if it's only right-sided, it's in the areas that cause neglect. And so it's probably is the neglect system, and that's how we should think about it. And finally, there's a thing called the multiple domain network. This is less than 5 years old, probably 3 years old. But the data there's a lot of really good papers that have come out on this recently. It's a mixture of different networks. You can see area 8C is involved in this. Parts of the central executive network, parts of the dorsal tension network are in this. And again, if you want to talk about where fluid intelligence comes in, the multiple domain network is a pretty good candidate, because it's been shown that the more of this you lose in a stroke, the more your IQ drops. Now, of course, the challenge is, of course, anything that hits this is hitting other networks, so it's a little bit complicated, but it's pretty clear that there is a core of highly cognitive demanding areas or highly cognitive demanding tasks. Activating these areas as a core set of areas to do that, and that's called the multiple domain network. So, okay, so that's the networks again. And again, I welcome any questions on this, because we really, if nothing you get out of this course other than that, I've done my job. But let's talk about how do we do plan trajectories with this. So with disconnections, you have to think about what's the plane, what's the, what network am I making the cut against? Trajectories are a little bit simpler because we kind of know trajectories. But of course, when we start talking about trajectories to tumors, this is different than a biopsy trajectory. So in biopsy trajectories, we spend a lot of time saying, don't go through the middle of a vein. When we're talking about tubes or cameras, what white matter you go through matters a lot, because you are doing some damage on the way to these things. And so how do you pick a good path? And of course, we all know the basic components. The target, which is relatively decided by the tumor or whatever you're taking out, the origin, which we get to set, and these two determine a path. So ideal trajectories would work as follows. Okay, so first, we don't want to go through somewhere bad in our entry point, and we'll talk a fair bit about that. We don't want this to go through the middle of a large-scale brain network. Okay, now sometimes that's not possible. So, as with everything, you have to use this in balance in combination with all the other facts that you have at your disposal. And of course, when we get to the target, we want to be hitting it on a favorable angle if possible. So there are a lot of other considerations you can have in this, but it really is, this is as simple as you can make it. And I think that this is plenty of nuance inside of that. And so we're going to base our discussion on that. And what we're going to do is, again, we use the software as a teaching tool here, because it can actually show you the brain networks. So give everyone a couple minutes to log on. And then we'll start going through a list of the trajectories in different parts of the brain, and how to figure out this, how do we think through this? So if you've logged on, the case that you're going to pull up is demo. We're only going to cover normal anatomy today, unlike last time when we had tumors, in part because to find an example of every possible trajectory here it would be A, it would just almost be impossible, but B, I think it's more important that we really try to think through this in terms of really what we're trying to accomplish with this few discussions about how to take the tumor out as possible.
Hey, Dr. Sughrue, we just have a question from Dr. Scarisbrick. When you discuss IQ drop, is this broad across all domains of IQ, or are we discussing specific aspects of the FSIQ? Example, the WMI or PSI?
The answer to it is that I think it's basically, and I don't remember the paper off the top of my head. I remember I read this briefly a while back when it first came out. So I don't know the exact answer to it, but I think it is basically more of the total IQ score. Now, having said that, I'd have to pull the paper. I don't know off the top of my head. Okay. So if you launch from here, and here, again, what you see is the montages here. And we're going to pull up the montages, but we're going to do a couple additional things here that we may not necessarily always do. And we're going to frame this in terms of regions. Okay? So the first trajectory we're going to talk about is the medial frontal trajectories. Okay. Now, while you can get to anywhere from anywhere, it's a, again, they're typical good ideas of, things that tend to be situations that you should consider using the medial frontal corridor as your trajectory. And so obviously things in the deep white matter of the anterior frontal lobe, that's by definition, you're going to be doing a trajectory like this. The frontal horn of the lateral ventricle and the caudate head are kind of the most common ones. You can access the insula, if that's possible, the anterior portion of it. Probably not the best way to do that, but possible. It's possible to get to parts of the putamen. It's also possible, but typically if you're doing those kind of operations where that makes sense, you're really doing more of a disconnection than you are a trajectory. And so for the purposes of this, we'll kind of focus on these three. Now, to review what is at risk in the medial frontal corridor. So you have the default mode network laterally, you have the Salience network lateral and posterior. It's your back wall, really. It's the connection between those two areas via the frontal ascending tract. And interestingly, if you're preserving the Salience network, you're not going to generally hit the corticospinal tract, because if you're in the medial frontal corridor and the Salience network is the frontal ascending tract runs right in front of the CST. So you're generally not going to be hitting that if you're preserving the Salience network. So kind of get a 2-for-1. And the frontal ascending tract, which again is linking up the Salience network. So these are the things that when you're taking a path are most at risk. Now, there's things laterally, there's, again, there's lots of things to think about, but in general, if you're going down this, and this is a very common corridor, this is where you are putting, the type of things that come into your discussion. Now, when you talk about where not to enter, now again, rules are for fools, and sometimes you have to violate this. But if you had to have your pick, areas that I would say that you should consider avoiding if at all possible. Now, if you're using the montages, a lot of these guys come up already. Basically, these areas punch above their weight as far as we have a known, oftentimes documented neurological deficit that comes from this. So for example, area 8AV has been shown in a recent paper out of Harvard that if you have a stroke in this area, you develop anxiety after the stroke, called the angiosomatic center. Area 46 has the same paper for depression. If you're interested, Michael Fox has written all of these papers. It's a very good work showing this. So we can't say that going through that, particularly on the left side, is going to cause these symptoms because it's left-sided problems. But you should think about it because, if you had to pick, this would not be what I went through. Now, luckily, these area AV is a gyrus. So if you're going transfocal, you're actually splitting the gap between these guys. But again, there's a little bit more in the dorsolateral prefrontal cortex than you probably thought. Now, this area is in the sulcus, area 55B. I would highly recommend not putting it in there if you can avoid it. And then area 8C, as we pointed out, is one of the major hubs of the brain. It's the hub of the central executive network. And again, if you're looking at montages, you should be avoiding these. So DMN, anterior cingulate, posterior cingulate, you're trying to stay lateral to this. The Salience network is on the back wall. You're trying to stay in front of this and stay with the CST in front of the last tract. So if you look at those two things, they set a boundary. So if possible, avoid entering into the area 8AV, area 8C, 46 if possible, and certainly try to avoid 55B on the left side. So let's just quickly show what that looks like. So we'll pull it up on left medial frontal on the left side. I'll give it a few minutes to load. Mine is probably going faster than yours, so I'll give you guys some time to load this. Now, one thing to look at inside of here, there's a little ruler, and you can do a couple different things with that. In this case, it's kind of a unique ruler. So if you pick two different points on two of the two-dimensional images, which are the three upper and left panels, it will actually plot the course in 3 dimensions. So it's a neat little engineering trick. And we'll use this today to kind of try different trajectories to different areas. Now, before it finishes loading, once it gets to a certain point, you'll start seeing the tracks come in. So to quickly just run through the networks. So default mode network, anterior cingulate, posterior cingulate, lateral parietal. If you look at the medial frontal corridor, the type of trajectories we tend to think about tend to be something like about this. So as long as you're not basically coming right down the midline, you're not going to be hitting this. But again, it's conceivable to think that you could take a trajectory to the ventricle that can put this at risk. So just be aware this is in there. And you want to try to basically stay more here than here as far as dodging that. Do you guys have demo in there? Is there one that called demo? If not, then we can do just type the word front. Yeah. So if you type if you go to the search line and you type the word demo and it doesn't work, let me know, and we can help figure this out. Okay, so moving on, you look at the Salience Network. Okay, so this also is a cingulate area, and it has this kind of connection to the anterior insula. Now, to show where that's in 3-dimensional space, let's just kind of go up on the axial here. Okay. And so what you see is that this just set the back wall of your approach. So everything you're essentially needing to be about here. Now we kind of are, most people probably are doing that. Ultimately, we kind of know that this corridor is reasonably safe. And part of it is that if you're here, if you look at it, if you're in front of the Salience network, you're also in front of the corticospinal tract, right? So if you're obeying that, you're also not hitting the CST. So it's not adding, it's actually making you safer on the CST. Now, of course, you may not be able to do this. There are people who have tumors in these areas, but that's an example. Now, when you pull up the central executive network, if you basically look at these 3 parts, the 3 main parts, notice that we actually are showing the whole C in here. You notice that they're linked by the SLF. And this little blob right here is 8C. So let's just go through here. It's one of the hubs of the brain. And if possible, you'd like to not cut into it. So again, if we look at it as far as picking a trajectory in this montage, it sits on that side of the sulcus. So this sulcus is reasonable. You might pick this gyrus, but the bottom line is, if you're going, right down this gyrus here on the side, you're going through the middle of 8C, right? So in general, if you had to pick, this is not where you pick as your ideal entry point. Now, we talked about a few other ones. So let me walk you through the other parcellations. Not because I always would pull these up, because if you're respecting the networks here, you're going to be missing those parcellations at the same time. But if you had to say, okay, where are these other areas? So what you can do is you hit plus, and that's going to make a little custom guy. Yep. So it brings up the whole brain again with nothing special on it anymore. And for those of you who want to get really detailed into this, so if you pick by individual parcellation, here's all the list of them. So I'll just kind of show you these guys. And these aren't necessarily saying that you can't go through here, because we probably have and get away with it. But these are things to take into consideration, and maybe someone will write a paper showing that this doesn't matter, or they'll write a paper showing that it does. But the bottom line is this is the standard FDA-approved target for depression on the left side. On the right side, it's probably doing something different. This is part of the Salience Network called Area 46. It's a Broadman area. If you come over here, let's add some guys to this. So let's go to Area 8AV. And show you where that's relative to Area 46 here. Area 46. And then let's go on to 8C. So this little cluster here has a lot of important areas right next to each other. Now, they're big, so you might be able to come on the boundary of this and not do damage to it. But, you know, if you were to say, would you rather be here or here, you'd rather be here. So that does, you know, again, you might look at this and say, well, maybe I should just stay really far away from 8C and its neighbors, if you can. And but that's another thing to put in consideration. To show you 55B, you get it for free at the language. It's in that montage. But let's just show you where it's located. It's not a big area, and it's actually the most highly variable area of the human brain of all the parcellations. But 55B lives all the way basically back here. So if you look at the hand motor cortex, it's right in front of it. And so those are kind of the entry point considerations. Now, if you think about how do we plan the trajectory? So let's clear this guy. Let's look at the Salience Network, okay? And let's go on to the 2D images. So we have the 2D images, and let's zoom in. How do you save custom montages? They're automatically, if you hit the plus and approve it, they're automatically saved. Oh, you're talking about custom, like if you want to make your own montages. It's a future feature that will be coming relatively soon, but it's not available at the moment, of doing your own montages. But it's something we're working on right now. So if you wanted to build your own montages, right now you'd have to do it. Ultimately, to be truthful, there's so that, you know, we're just hopeful that people can grasp the basics of the software right now. And if we end up having power users, we'll start to build things for them as we go forward. Okay, so we hit this little ruler here. Put a dot here. Now, let's say I want to go to the frontal horn. So maybe the coronal, I want to see this angle here. And that's my trajectory, right? So let's say I decide that trajectory. What I want to do, if you look at the 3D, is to follow this and look and see, am I transgressing a network anywhere along this? And that's the useful thing about this, is that, of course, as we know, you can do this in 2D by just scrolling through it over and over again. But notice that this gives us, oh, well, hey, guess what? That trajectory looked fine, except for here, you're dinging the part of the cingulate gyrus here. So what we want to do in that situation is maybe pursue this more lateral. So let's just try. Now, one of the things about this is that it doesn't save the ruler. So that's, again, something that we'll be working out in the near future. So let's just look at this in this trajectory here. So still a little too close for comfort with the Salience network. So let's try moving this a little bit anterior here. So maybe, for example, here, and then we'll come to this point here. And if you look at, let's look at this here. Okay, good. So not a bad little trajectory. Now, if we go to the CN, the next question is, did I just pick an entry point that puts me into the middle of 8C? And the answer is no, not really. This is 8C here. We're close. I mean, we may be dinging this thing. So you might move this medially. But the bottom line is the trajectory we're planning here is not bad for the CN. It's not going through the hub. It's not going through the middle of the track. Obviously, with the DMN, if you're missing the Salience network, you're gonna be missing that by a lot. And if you're missing the Salience network, you know, the S-line track, you're gonna be missing as well. But let's just confirm that. Oh, maybe I'm wrong about that. Yeah, okay, well, there you go. That's why you do connectomics. So what we might want to do is hit the target, the entry target at a different, at a slightly different angle, because obviously we don't want to, if we can, we'd like to not cut the S-line track. So there you go for that. So let's try, maybe we enter at this angle and let's put this here and here. Okay, so let's see how that works. Yeah, there we go. So that's a little bit better. We can play with this some more, but of course, then what you want to also do is make sure that you now are not going through 8C or part of the CN. There you go. Salience network, we're good. Default mode network, we're good. So that's kind of how I would think about planning a trajectory here. Now, again, on the right side, we're going to have, you know, in this case, a lot of the similar networks. But, you know, again, you could think, well, okay, what about the language system? Well, let's say I wanted to look at that. So I go to my custom object. I can pull that up, right? There's no reason I can't. You can look at network template and talk about language system. And there you go. This will tell you whether you're, you know, hitting it. In general, if you're saving the Salience network in the ASLANT tract, if you're in front of the ASLANT tract and you're medial to the central executive network, in this region, you're generally not going to be close to the language network. But if you're concerned about it, you want it on there, there you go. That's how you do it. Okay. Does anyone have questions? Okay, so to get to the next trajectory, just X out here in the upper right. We're just going to load demo again. And then we get here, let's do the left lateral frontal. So we're going to cover next. Then while that loads, we'll just briefly discuss it. It's going to be similar, right? So if you understand the medial frontal, you're going to understand the lateral frontal because it's, you know, just different angles of the same thing. Now we talked about the lateral frontal disconnection last week. So some of this will seem familiar. And of course, if you've done language area surgery, you kind of are going to kind of know some of these issues. So you know, the program to areas intersected. Yeah, that's a good thought. It's something we can certainly build into the future. It's not that hard to do it. Eventually with machine learning or trajectory planning, yeah, of course, that's what you would eventually want it to be able to do, is to tell you to hear the optimal trajectories. It just, It's just, you know, a little bit complex for two reasons. Number one is building it. That's actually not the hard part. But the hard part is getting the FDA to be comfortable letting you do that kind of thing and the risk category. So it's certainly not that hard to go say, you know, optimize around these things and tell you, this is a path to go to this target. So if you say, here's the target and here's the corridor I'm in, optimize onto that. I'm sure it's fairly easy to do that. But ultimately it comes down to how do you get the FDA to agree that that kind of thing is okay to do. And they're getting open-minded to that, but they're still a little bit squeamish about this for obvious reasons. And you know, as a company standpoint, we first wanted to get the product on the market. And so next thing you know, we do it the nice fancy way. And then talk about lit. I think lit is a fantastic treatment, and that we should try to push that as far as we can. I've done lots of lit. I think that it's great. Having said that, of course, you know, what we know is that there's a couple challenges. Number one is, you know, getting coverage of particularly big lesions gets really tricky. You know, I've done 6 laser treatments before. And, you know, in general, there's just limits to what you can do. The second thing about it, of course, is the fact that if you're treating a big lesion, you're often going to get some significant blood-brain barrier opening and problems with it. And so just like everything, if you push it into a situation that it's not good for, you're going to find out that you oftentimes are going to regret that. You know, for example, if you're talking about that big case I showed at the beginning, just take it out. It's just, trust me, it's better for the patient. But as far as getting some of these deep-seated things, lit has some really great properties. It really conforms to the lesion in ways. And of course, if you can eliminate the path to the lesion, you've already eliminated some of the morbidity. And of course, we know lit lasers can take paths through terrible things that we would never, you know, dream of cutting into. So what I would say is, whenever possible, it's a good thing. Now, of course, you know, if you don't know where the networks are, you can't put a safety margin around it to say, turn off the laser if you get to if this gets too hot. And so, of course, having that kind of information around the lesion can be also very helpful as well. What I'll say is that we're not necessarily, I'm not necessarily wedded to the technique. What we're really trying to get across here is that how do we use the type of knowledge that Connectomics can do to make better decisions in that? Because again, ultimately, you know, where you could think about in this particular situation is if you were on the fence, but it turns out to get to this thing, there's just no path that doesn't take you through, you know, 8C or through some other area that you didn't know 5 years ago that you shouldn't really think about. You should think about not cutting through. Well, that may take, say, let's try lit here, because even though we may get into edema issues, it would be better than destroying that part of the brain to get to it. Whereas if you find a clean, simple trajectory and it's a big lesion, you know, lit may not be the right answer for that case. So it really comes down to, you know, we're all smart people and we should try to, you know, make good decisions. So if you talk about lateral frontal trajectories, these are less common because anything coming from the side is going to bring you in contact with the SLF and IFOF tech networks. And, you know, it's if you had to pick between, you know, tangling with them or not tangling with them, you generally try to stay medial to them because there's a lot of stuff out there. You prefer not going through it, but sometimes it really is the shortest path or the best path or whatever. And so, like everything, we should think about it. And really, again, it's very uncommon that I would recommend the lateral frontal trajectory to get to the frontal horn, unless there was a compelling reason, like the tumor, you're following the tumor there or something like this. But if you're talking about a deep target, if all you want to do is get to the ventricle, the medial frontal corridor is better. But let's just talk about it, because if nothing else, it's going to teach us about networks. So what's involved here, and you can see the list is long. A lot of these things are right, you know, either next to each other or compete or, you know, connected. So the central executive network we talked about, the frontal aslant tract is part of linking up, mainly linking up the salience and language systems to their components. The language network, I have to tell you, is here. the corticospinal tract. Eventually, it's pretty far back, so it's not usually part of it. If you're paying attention to these other guys, you're not playing chicken with the CST and sensory motor system, but they're in the montage for obvious reasons. And so, what are the cortical areas that we need to pay attention to? Now, I talked a lot about 8C. It's the hub of the Central Executive Network. You're now seeing it from the other side. And also Area 44 and Area 45. These are part of the canonical Broca's area. So again, I say that if you're picking a trajectory, going through Broca's area is probably not a good entry point. So I don't need to tell you guys how to suck eggs, but you should think about not cutting into these areas. So let's kind of run through this trajectory, and for some reason, well, there it is, it's done. Okay, so what we're going to do for purposes of this exercise is to come in here. So what we're going to envision is that there's a lesion here in the lateral deep white matter. We're taking a medial frontal trajectory. It's going to be bad. And that this does not come to the surface or anywhere close to the surface. So it's approximately here. So what we're going to think about is how do we plan a reasonable trajectory to what is a small but dangerous lesion. Okay, so I want everyone to kind of pay attention to, in the past, this would be a simple discussion, just straight in and hope for the best. And a lot of patients do fine, right? I mean, you know, we get lucky a lot of the time, and it's possible that the other side can compensate. And again, it doesn't mean that we should never, ever take a trajectory like that. What it is saying is that if we want to try to do the best surgery we can, we would try to, you know, make our best effort to not cut through the middle of this network, especially the CEN. And so, because again, it's the difference between being 15 and 30 is that. So unless you think there's nothing of value that's been gained in that period, you should probably not try to destroy the network that makes us an adult. So if you look at this in a couple different angles, the Central Executive Network, it kind of sits here like we described in the talk. So frontal pole, 8C, and here we have this lateral parietal area. So this is the CEN's core. A lot of other parts to it, but that's the core. Okay, so right now, if we're working in this little corridor, we've already limited ourselves. Okay, so that's your upper boundary. This is your anterior boundary. Now, if you look at the language system, that limits us as well. So you're in this case, you're picking the least bad path. So you might decide in this case that maybe a transsylvian transsulcal approach to come underneath this. That's a reasonable angle. You know, you can come up with a lot of different things. But if you were taking the shortest path, what you really almost are trying to do is split the goalpost between this guy and that guy, right? So something maybe here. So let's pull the ruler up, click there, and let's go to this one. So actually, hold on. Click this as our entry point. Want to be on the cortical surface, obviously. And if we zoom on to the, let's go back to that sagittal. Okay, so yeah. Okay, so we put that here, and then okay, so that's our target. And let's go back to sagittal. Okay, so that's what I've kind of aimed as my trajectory. So let's go look at this on the 3D. Okay, so Okay, so let's say we're aiming to that thing. Okay. Okay. Okay, so let's just examine that trajectory. Okay, good, we got that to work. Okay, so this is a trajectory that goes right in front of the language system. This is cutting it very close. So I would be, really cautious doing this, but let's see what that looks like on the C end. Okay, so let's zoom in real quick because packed house in this thing. Yep, you can see it right there. So what we would have to hope is that this lesion has split these networks in some way. So you can see that it's sort of challenging. And in many cases, this might be a better angle, right? Is to come from up here. And just to show you why that's the case, that may be your better angle into this, even though the direct approach, you can do it. You're not actually separating these guys out by going down the sulcus. It's a very tight fit, right? And so there may be situations where tumors splayed these out. Often that's going to be the case, but it shows you how narrow the lateral frontal corridor really is before you're bouncing into at least one of these networks. Now, if you were to go and trim one of these parcellations and leave this connected to this in some way, and come underneath that bundle, yeah, you probably aren't going to leave the patient seriously hurt, right? But what it comes down to is that one way or the other, that corridor isn't as friendly as you probably thought it was. Now, of course, if we look at the other networks, the Salience Network, we're well behind, we're well in front of that. CST, not so worried about. And then if you look at the sensory motor system, what we included here, this is that area that's part of the motor planning area for speech. It's called 6R. And so it's kind of, I think it's where the speech arrest site is, though as far as I know, nobody's gone and validated this with cortical mapping. It's an interesting project of which parcellation is actually the speech arrest site. It's probably not area 44. So, for example, there's people who come out and said that, there is no such thing as Broca's area. Well, of course, there's some such thing as Broca's area. It's just not a speech arrest site. So maybe that's tolerated when there's a tumor there. I mean, there's a lot of questions before we conclude that all of the entire neuroimaging and neuroscientific literature on this topic has ruled that area 44 has no role in language. But I think that one of the questions really comes into who are the areas that we're finding in intraoperative mapping? And I don't think it's entirely clear. Okay, so that's the frontal corridor. Let's move on. And so again, exit out, load the same case. In this case, just to show you what we'll be doing next. We're going to the temporal lobe. So, and we'll do the left side. The right side, I'll show you real briefly at the end of this. But when you talk about the temporal lobe, you think, well, we're not doing a lot of trajectories there, right? And it depends on what you mean by trajectory. The answer is we need trajectories in the temporal lobe all the time. You're just not doing it in the way that you think, right? So what you're probably not doing is this extremely long path or sticking a biopsy needle or all these things, putting an intraventricular camera. But I found that when I started thinking about this way, there are a lot of situations that I was taking a trajectory of the temporal lobe. For example, let's say I had a very large glioma, but I wasn't certain 100% that it was a glioma. There's some weird thing, and I wanted to make sure that I got a frozen section cooking so that I didn't do a temporal lobectomy on someone who didn't need a temporal lobectomy. And so, maybe this is a ganglioglioma. Well, it doesn't make sense to do a temporal lobectomy for a localized tumor. Let's say this was not a tumor, it was some other thing. And so what I would do is I'd try to get the frozen section cooking, I'd do the cortical mapping and all that sort of thing. And I need to get into the temporal lobe, get this biopsy, get it sent so that we weren't sitting there with an awake patient for 45 minutes waiting for a frozen section to come back or whatever before proceeding. So that's a temporal lobe trajectory. There are also, I pointed another one, which is there are localized tumors for whom doing a lobectomy isn't necessarily the best way to do that operation. So there are a lot of reasons to do it. And there have even been some papers about people promoting temporal lobe trajectories, some of which that actually when I saw it, I was kind of shocked. I said, if they had the anatomic information I had, that is not the trajectory you want to take to this. So it's worth thinking about when do we do it? And essentially, these are, besides just getting into a specific tumor, typical places where trajectories come into it is if you're needing to get into things that are in the temporal horn or around there, like the hippocampus, amygdala, or areas inside the temporal pole, oftentimes trajectories are what we're talking about. And there are a lot of things that run through this. So now, some things like the corticospinal tract, for example, not really at risk in these types of operations. IFOF is over the top boundary. So again, if you're really staying inside the temporal lobe, you're generally not going to have IFOF. It's not running through the temporal lobe, it's above it, but it's in the region. But typically transgressing the language system and to a lesser extent, the accessory language system are things that we should try to avoid. And on the other side of it, you have the ILF. So what you realize is this is going to squeeze your corridor a lot more than you think. And so, again, if you had to say, what are the areas that you should not prioritize as going through, okay? So if you look at the very temporal pole, it wouldn't be where I would pick, particularly on the left side of an entry point. Now, sometimes it is the shortest path or the tumor's in it or that kind of thing. But if you had to say, is it a good idea to go aim at the temporal pole and pick that as your entry point of choice? And the answer is no, I would try to be lower and more posterior. But then on the other side, I don't want to be too posterior. So it's that little window between these two worlds that you're working in. It's also, I would say that being in the superior temporal sulcus is also ill-advised as well, because again, there are functional areas at the boundary of it. So let's kind of go to the tape. Okay, so what we're going to think about here from a standpoint of thinking about trajectories. So again, we're on the left side in this particular montage. And you can see that what we're thinking about getting to is the hippocampus. So this is kind of our target right here. And what we're going to think about is we need to get to the hippocampus without taking out the whole lobe. We're doing some transsylvian thing. Because maybe if for example, you can obviously do this through a selective, you can obviously do lit. What we're talking about is, let's say the whole temporal pole is, some lesion, all this medial stuff. And if it was the case that this was a glioma, it would be very hard to get a complete resection, get a good angle, et cetera, and you may even consider removing portions of the temporal pole. How do we get to this little medial structure doing as little damage on our way there? So obviously the CST not really in the mix here, unless you're really high up in the temporal stem, at which point you're not really in the temporal lobe, you're somewhere else. So not so worried about that. IFOF, same sort of scenario. If we look at this in sagittal plane, the IFOF is not in this operation in general, but there it is. Let me zoom in a little more. There you go. So again, if these are considerations, you're doing a different operation. You're doing a temporal insular tumor or something, and you might want to think differently about your operation. This is the one that is definitely in the mix. So let's just zoom out real quick. Okay, so with the temporal disconnection, this sets your back boundary. Okay. And a lot of times when you're dealing with the kind of thing that requires disconnection, you're making this cut as part of the operation. So you basically disconnected this from this. So at that point, there's no discussion. But if you talk about how do we do the best surgery we can for a trajectory, let's say that's all we're doing is a trajectory, what is our best entry point? And I want to draw everyone's attention to what happens if we put the entire language system on here. So here we have this accessory language. And there you go. All of a sudden, this became a little harder, right? So, you might decide that this is the angle, you want to be, for example, this is this little chain of things that run on the middle temporal gyrus to the temporal pole. And this probably, you're increasing your risk of getting a verbal memory deficit. That's my thought on it, having studied this for a few years. So this pushes you about here, right? And the issue is that if you think about what you're competing against, you're competing against the ILF. So this window has gotten a lot narrower. Now, you may not be able to navigate this perfectly. What we're hoping is, obviously what we always hope for is that the tumor does some of the work for us. But the bottom line is, if you had to pick, you've got a little bit of complexity here. So let's put an entry point about there, and we're going to see what that looks like. Okay, so that's a trajectory. And going to the 3-dimensional, let's just see what that looks like. Where did it go? Did I turn it off? Not there. Okay. Okay, there we go. So as you can see, we're just skirting underneath that system, right? Very close. So we might want to move our entry point a little further down. And the issue with it is, if I take this trajectory here, actually almost going through the middle of the ILF. So you're a rock at a hard place here, right? There's not a perfect one. And so you might decide to balance between the two and say, okay, well, maybe I'm going to basically come a little higher because I've got to cut something to get here. And so no matter how you do it, you're again, there's not a perfectly easy way to get to this that doesn't have some kind of consequence. But what you're trying to do is balance these things. And so even if you're up here higher in the middle, you say, forget it, I'm just going to go through the accessory language system. So let's say I'm going to ignore this and move up here, you're still going through parts of the ILF, and at least some fibers. And when you look at everything. Just below the surface. So it all comes down to, in the right side of this is a little easier, because even though the same exact anatomic system exists on the right side, we don't know specifically what it's doing. In Chinese people, it's actually the language system. So it does the same thing on the right side and left side because it's a part of the tonal system. And we've shown that the Chinese language system is fundamentally different than the English language system, which explains a lot of things about Chinese to English, learners and vice versa, and why we have struggled with it. Our language systems are wired fundamentally differently. Now, on the right side, no matter how you're doing it, and I think what we say is you're making a decision. And in this particular case, on the left side, I would personally try to be lower, avoid this system, and sacrifice some of the ILF. That might be the wrong answer, but based on what I know now, that's what I would say is your best option. And again, this may be one of those situations where the cued approach is the right approach, the only approach there. But still, if you get down to it, how do you avoid this thing, right? It's a wall. So, having said that, I found that if I had to pick, the ILF tends to be, at least anecdotally, a little bit more tolerated. So while I would try not to just blow through the bundle and not make any effort to think about it, it's unavoidable. How else are you going to get to this? Now, that would be the argument that people would make for doing selective amyloidotic connectomy, and there's some reasonably good thought process. But if you think about how does this information make it from the temporal pole here, it's the uncinate. So how do you get into how do you do a selective that doesn't cut into that? I mean, you're going to get very likely get some of those fibers. So you'll do less damage, but you still do something. And so again, this is one of the best arguments for RIT in this kid situation for this situation, because there is no easy way to get in there. But I think the way to think about it is that what I hope I got across to everyone is that these kind of discussions are really important that we continue having as a specialty, because the idea that you just go in there and there's never a consequence and everything is great probably isn't always true, right? I mean, it's hard to argue that you're cutting through some of these things and there are no consequences to it. So anyway, okay, so that's the temporal one. Now I'll show you really quickly, if we load the right side one, what comes in there. And you're welcome to follow along if you want, but we won't be spending much time on it. But what is the difference between the right and left side? And if you remember from last week, a lot of the things are the same between right and left. The biggest difference is what generally happens in the montages is that where language is used on the left, the ventral tension network is on the right. Because the same exact situations anatomically where you would be thinking about language on the right side of the brain is that you're thinking about neglect, and the ventral tension network is a good surrogate for neglect. It's probably the best model we have of it. And it is kind of striking that a right-sided only network exists that's involved in paying attention. It's kind of a very likely culprit. The evidence seems to suggest that's true. So where this would limit you is a little bit less, actually. It's not as big of a network as language. But for example, if you're talking about the temporal areas, now the question, of course, is, there's an analog, the exact same anatomy exists out here, but I can't tell you what it does. And so, that means that until further notice, I won't tell you necessarily to spend as much time on the right as on the left. But of course, you might find out that this is doing something incredibly important, and you have the same discussion, the right and the left. But you see that it's not exactly the same as language, but it's a lot of the same situation. So in the right lateral frontal region, you bump up against it. The right lateral parietal region, you bump up against it, etc. We'll take Q&A here. Oh, you're welcome on this, whatever I answered. Okay, so the next one we're going to do, get everyone across it, is insula. Okay, so when do you ever need to go through the insula? And the answer is, it depends on how you're doing it. So maybe I'm old-fashioned, but I don't know if anyone's necessarily putting a tube through the insula, though maybe someone is. But certainly a trans-sylvian approach and a transinsular approach has been done. And so in the disconnections, oftentimes when you're doing an insular disconnection, you're doing it for a glioma, right? Because that's not a rare situation. And insular gliomas are rarely located just in the insula. They usually have an opercular component, often have a temporal component. And when it comes down to it is, if the tumor is involved in the operculum and the operculum is sacrificable, it certainly makes the operation a lot more easy, effective, you get better resection. And so we shouldn't necessarily be afraid of that. But if you're thinking of the insula as a trajectory, then the trajectory is generally trans-sylvian. There's no, you might think about removing a portion of the operculum, but honestly, that's defeating the point of a trajectory, at which point you're doing an insulectomy or something like that. And those operculum are doing things. They're doing often some interestingly important things. And so where this is useful, and it's really only one situation that I ever considered going through the insula as my approach, is to the putamen. And the reason, and I'll take you through it really quickly. So if you look at the putamen, it lives here, and the insula is a very nice, simple trajectory into that area. Now, not a lot of reasons to go into the putamen. Interestingly, in my experience, gliomas do go in there, but it's rare. They tend not to involve the basal ganglia. They push it out of the way. So a lot of times what people think is a basal ganglia tumor has just gotten so big that it's displaced. So spending some time looking through that. And if you're interested, if you really want to get into the details here, sorry, it's going to be here. And if you look under the subcortical one, now notice that we, as pointed last week, you can basically blow up any of these guys and find things. And so, you know, if you're a power user, you know where to look. And then here we have to turn the parcellation back on. So let's turn that on. But look, it shows you the putamen's right there, right? So obviously we know that the medial boundary of the putamen is bad, you know, but oftentimes what you find out is that this has been displaced. And so machine learning isn't perfect at this, but it's pretty good at finding basal ganglia. We're trying to get to see if we can find subcomponents of basal ganglia. But, you know, again, this gives you an idea where that's located. And, you know, if you were to look at this particular situation, let's look at all the other boundaries besides the fact that the corticospinal tract draped over this thing. So if you look at the insula from here, let's look at, for example, the language system, and let's look at it in the sagittal projection. So pull up this, zoom in, go to the sagittal, come out here. So right here, you have a lot of things just, you know, this is, you know, basically a lot of fibers, arcuate, parts of the SLF2 running over the top of this. And if we pull up IFOF, there you go. So now any approach that gets you anything other than this direct angle is going through something. And, you know, if you're in this area, you're talking about damage minimization, right? I mean, it's if you have a lesion that for which open surgery of some kind in the putamen is the best option for that patient, things have gone wrong for this person, and you're trying to just get them out of a very bad situation. But I found that this approach actually can be very helpful in certain people. I've done it a handful of times. Not something that I recommend doing on a regular basis, but it's an angle into the deep brain that's reasonably safe and non-damaging. Now, the one thing to think about, and this should give pause, is that the insula does the Salience network's in the insula. And in fact, the hub of the Salience network is right there. It's called an MI. And so again, you're not going to accidentally end up here if you're going to the putamen, but the main issue is that you really want to make sure that you get at least somewhat further back. And this requires a little bit more sylvian fissure dissection to do that. So we won't belabor that point, but the bottom line is that's the one trajectory that you could take from the insula. And now let's do another workhorse one, which is the medial parietal. And so the medial parietal trajectory takes us to a lot of places. It's one of my favorite trajectory corridors because it's the only safe thing in a very dangerous part of the brain. And so it's a workhorse for getting to the atrium and the lateral ventricle. And as such, it's a workhorse for getting to the thalamus, the fornix. You can also get to the splenium, the corpus callosum. And in some cases, if you have a lesion that extends into the medial temporal lobe, it's a preferable angle than coming from the side for reasons that I described. Because it isn't that there are white matter fibers there just aren't networks there. And you don't get that many bare spots where the networks actually separate out for you, the tracks separate out for you. So I think one of the key things about it is that the trajectories tend to put you towards the center of the white matter, and as opposed to the lateral and medial components where all the tracks are running that are linking these networks up and the components that these networks live in. So pulling this up here, let's pull up the medial parietal montage, and we'll talk about the trajectory. So, and just for interest, let's do the right medial parietal. Though the language is the same. So again, remember that where the ventral tension network comes in, you can just flip it for language on the left side. They're in a lot of the same places. And so they're not identical, but they're close. Which is probably why that the ventral tension network is lateralized to one side, is that the language parasitized that system on the other side for speech and evolution. That's my theory, at least. So as we wait for this to load, we'll just talk a few technical nuances. So networks involved in this. Your front boundary of the corridor is the corticospinal tract. So unlike on the back, where you have the front, the medial frontal kind of side, where the Salience network will keep you out of the CST. If you're in front of one, you're in front of the other. Now, sometimes I've seen tumors split those two networks, so you know, all bets are off. But in general, most of the time, in front of you have a wall in front of that to keep you out of it. In many cases, here you don't have that. You have the sensory cortex is the very front of the wall. So you have to be a little bit more cautious of that being your front boundary. The language system / the ventral tension network in this particular case is the lateral boundary. And if you're preserving this system, you're also preserving the optic radiations, you're preserving the IFOM. So the way to think about it is you have this little four-sided box where the back of it's the visual system, the front of it's the motor system, sensory motor system, the medial boundary is the DMN, and the lateral boundary of the lateral system, language and ventral tension network. If you're staying in that box, you're actually basically okay. And again, it's amazing that our ancestors figured this out without having all of the facts of why this was a good approach. But the superior parietal lobule is a great approach from an anatomic standpoint. It does the least amount of damage. Now, if you look at the areas that you should think about not going into, okay, there's a bunch of them. And notice that the word IP shows up a bunch of times. This is the intraparietal sulcus. So this is a situation where a sulcus is often better, but not always better. And the anterior portion of the sulcus has a lot of important areas that are parts of the dorsal attention network. Some of these have speech and language considerations. Some are ventral attention on the right side. And so, you know, if you're going to try a port, pick a different sulcus or go further back in the sulcus, because this is probably not where you want to be hanging out, because you'll be going right to the dorsal attention network. Having said that, you know, there are situations where there is no avoidable way to do it. And so, you know, ultimately, if you're talking about some of the problems we're treating, they're terrible problems. And we don't necessarily want to be cowardly and avoid all of these. What I'm basically describing is, how do we minimize it? Okay, if we have to be there, how do we minimize it? And if you have a choice, you don't want to be there. So let's find the four sides of the box. So you can see 1, 2, 3, 4. There they are. And if you pull up this is the sensory motor, so the corticospinal tract. Now, notice that this in a montage, this generally defaults the parcellations off. And I can go into the reasons why we did that. But in short, if you want to see them, there's the cortical regions of it. Now, if you blow this up, what this is basically telling you is take all the motor areas and motor planning areas and show us the connections to the brainstem. That's how we pull this out. You can see the CST here. It's nice and robust, but ultimately this becomes noisy and it makes it hard to see. So in general, we default to this off. So, you know, you guys are taking a course in this, so understand that there's a lot more options that we can go into on how to really use this powerfully. But basically, for obvious reasons, in general, unless you have a very, you know, tumor that's in here, in the system, then you should try to be behind this for most of your trajectory. So if you're trying to get to a deep target in the white matter, the ventricle, et cetera, be behind this. I don't have to tell most people that, hopefully. If you look at the axial system, you see that this is where the optic radiations are starting to come back here. And ultimately, that kind of forms your back boundary. So that's pretty far back. So in general, a lot of your angles in this approach are going to be something like this. And so that is you know, it can be a little bit challenging when you first do these of how you land in the ventricle, but and sometimes it is a much longer trajectory than you would plan otherwise. But you know, my experience is that this is the least damaging of the approaches. This is the one that tends to be the where the discussion happens in these cases. The lateral boundary, that's the one that's most variable between individuals. And so, you know, where that's located, but you can see that now you've set your whole anterior and posterior wall of this thing is staying away from the ventral tension network. And so that's your biggest corridor limiter, and your other medial corridor is this. So as you can see, you basically have a nice little trajectory that, you know, corridor that, you know, splits all of these differences. And so let's pull the ventral tension. I'll use that as my anchoring point for planning this trajectory. And I'm going to plan a trajectory to the pulvinar. Because if you can get there, then a lot of the other things this approach corridor is useful for are, you know, derivative of that. So let's come here. Okay, there's the pulvinar. So put a trajectory in the pulvinar right there. And let's look at where we want to be. Okay. So should do that on the correct side. That's the one thing that I will recommend when you're going between 2D and 3D is that here we have a radiographic projection, but you can't really do a radiographic projection in 3D. So just be careful. But luckily, the computer is smarter than I am. Okay. Why is it making it? It's weird. Oh, there it is. I don't know why it's doing that. And then let's come out here. Okay, so we have our target. And you can see here, this is, you know, the interparietal sulcus, nice and unfavorable. So in this case, let's put that there. And let's see how that does. So come to the three-dimensional. Okay, looks like a trajectory there. Okay, so you look at it along its path. It looks like we're doing a pretty good job dodging that. So let's go back and look at the other guys. Okay, managed to not go through the motor sensory cortex. And good. So you see, this is one of the nice things about this angle is that it's a little bit longer. I mean, there's shorter paths that you can take to this thing, right? But that's not the point, right? The point of it is you're well behind the direction of the corticospinal tract, so you're not likely to veer into that at some point in the operation. If the cavity expands as you operate, you're not going to be abutting this, etc. And the last one to take into consideration is the DMN. And so you see that, yeah, you're doing a pretty good job, right? And that's the nice thing. It's a nice luxurious corridor for once, which is one of the reasons I like this approach so much. One other thing I'll just show to you, it's not part of this montage, and partly because if you're using this montage correct, you're not going to be encountering this, but you can see that all these guys here in the dorsal tension are the interparietal sulcus components. So even though you're actually getting slightly closer to the sensory motor cortex, you're actually safer here than in the sulcus. You could move this here, and again, you could play this a little bit. But bottom line is that you really want to stay medial to the sulcus here. Otherwise, you're going to be disconnecting this network from itself. And then we'll cover one last trajectory. because I'm sure I've overloaded everyone with information. And this would be the lateral parietal trajectory. And the short thing is don't do it. There's too many things. The only time to ever to be taking this path is that the tumor is in this area, and at which point it's not really a trajectory. You're really just doing a very detailed micro lesion resection. There's too many things. If you haven't noticed that are draped over this, that the only time to be there is that the lesion is basically in that lateral parietal area. So in general, I can't think of a deep target, maybe someone can correct me, that the lateral parietal approach would be the one that I would aim for. So because you basically, no matter how you do it, you're going through multiple track bundles, you're going through multiple networks. It's really not a place in the brain you want to be. And you should think about what the lateral parietal lobe is. So just to give everyone a quick little soliloquy on the lateral parietal lobe, the intraparietal sulcus areas that are named, the AIP, MIP, they come out of the macaque, and they're describing where they sit in the macaque intraparietal sulcus. So in the human one, the medial intraparietal is actually posterior on the superior bank of the intraparietal sulcus to the lateral intraparietal, because they're naming it for the macaque analogs. And so the reason they're all jammed onto one sulcus is that the lateral parietal lobe is in humans is unique to humans. Macaques and other monkeys don't have any of these analogs. And so what happened is evolution, we developed a new structure that was human specific that jammed the entire inferior parietal lobule into the SPL in humans. So the bottom line is, if you're going through this part of the brain, you're going through all the stuff that makes us a human being. And so I recommend being, strongly critical of any thought to go into this. This part of the brain is your path. Having said that, there are some concessions ones. So the anterior occipital lobe has some reasonable trajectories. And this is where you can get into things like the inferior cingulate gyrus in the back of the hippocampus. And so these regions are, not like there's a line between when you pass one and enter another. But let's just quickly look at why the interoccipital can be acceptable in some cases. Now, again, in many of these cases, you're picking the least bad path, because if you're trying to get to something deep past the language system, there's always a challenge. There's not going to be a perfect path, but the interoccipital corridor can often serve as a least bad path in this region to get to some of the deep structures. And so there are cases where you're working with something in the back of the hippocampus or the parahippocampal gyrus, where this is the best target to it. Now, having said that, you remember the discussion earlier, the episodic memory portion of the parahippocampal gyrus is where this is taking you. So, again, it's the functional equivalent of cutting one of the fornices, but we know we can do that in some people on one side, and it's not devastating. And oftentimes people already have tumors in these areas or have lesions in these areas or seizing and things like this. But notice that this corridor is actually also the lit corridor. It's actually the angle that you put the laser at. So it's, from a trajectory standpoint, you're actually coming at the hippocampus at a very favorable angle. And so it's often very easy to if you need to do a complete hippocampectomy for some reason, to do it on this trajectory. Whereas if you're doing it from the temporal side, as much as we're familiar with it, you're working back on yourself. And so I wouldn't say that this is my trajectory of choice for this. I tend to go from the temporal side whenever possible, for various reasons. At the same time, if you have to be there for direction reasons, just understand that you can actually follow the hippocampus from back to front, and it's sometimes easier that way. So the interoccipital, the corticospinal tract's on here, but that's not really what we're worried about. What our corridor basically is defined by is the optic radiations, which you can see here form kind of the deep boundary. Now, to be honest, if you're considering this angle, you're already first thing limited to this anyway for other reasons. But number two is the optic radiations may not be the issue that you're trying to preserve at this point. They may be gone or whatever. So again, it's always about thinking about trade-offs. But if you look at the reason the anterior occipital corridor is favorable compared to the lateral parietal corridor. Is lateral parietal is here, right? So, you know, and in the dorsal tension network, as you see, is a very similar set of places. So you're going to be hitting it. And so, yeah, if the tumor is in this area, then you have to tangle with it. But if you're trying to go somewhere else, this is not where you want to be going. This is not so bad, actually. If you look at this corridor, not so bad. So you can actually get, you know, if you stay behind the system and you work in this space, you're not doing so bad, right? Now, dorsal tension network will change that a little bit, but still not so bad, right? If what you're trying to do is get deep in here. So I'll just show you one potential example of a good trajectory for this. So if we zoom in here, again, being on the correct side of the head. And the dorsal tension network is a little bit behind the language system, so we'll use that as our front boundary. And let's take a trajectory here. Okay, so let's say that's where I want to get. And let's come up a little bit. It's like to not be near the sinus. So maybe here. Okay, so let's go to the 3D and let's see what that looks like. Now this is a long trajectory, but like I said, long isn't always worse, you know, so the bigger issue is, you know, obviously you have to think about how you're going to reach that, but if you position the patient kind of like that, that's straight up and down. And that's right down the barrel of the hippocampus. You have a good view of it. And it's not taking you on the trajectory that the inherent angle is, where if you get disoriented, you're going to end up in the corticospinal tract or something where you don't want to be. Once you find that you hit the ventricle before you get to anything dangerous, and again, that's kind of why it's the lit trajectory, right? Now, with this trajectory, it gets you, you know, keeps you behind the dorsal tension network. You can always look at the optic radiations, and you're skirting them for sure, but you're paralleling them. So hopefully you're minimizing the damage. There's no great way to do this. Now, I wouldn't say that if you're trying to get to this area, that this is the ideal trajectory to do this. There are different ways to do this. But if you had a tumor that was going all the way along this in some way, and there are tumors that do that, this is a pretty good angle to get there. And so if you're dealing with these kind of issues, I think what the principle ultimately it comes down to is there are some patterns and safe corridors into the networks. This is a reasonable one. Not to say there aren't consequences. I have seen some people have alexia from tumors in this area. But oftentimes when you're tackling these issues, you're dealing with much more difficult situations. So where this may not be the biggest threat to the patient's happiness. Having said that, we want to try to, again, in this case, you're basically minimizing the number of things, major things you're cutting across on your way there. So I think that kind of gives everyone a pretty detailed run through different trajectories, how to think through this, how to think in terms of networks. You guys can see there's actually the Great Barrier Reef behind me. So I thought it was a pretty cool place to teach a course. If anyone has questions, I'm happy to take them. And obviously, feel free to reach out to me if you guys have further questions or you want to get in more depth on these topics.
Well, Michael Lloyd, just a yeoman's job of information that I think is just remarkable, amazing. I run out of adjectives. You know, there's a lot of seminal events, I think, in neurosurgery. Go back to ventriculography or CT or MRI. This rewrites neurosurgery, at least in my mind. And, all the other things I've seen and I've tried may have improved my approach, but never explained my outcomes. And this gives me an opportunity to start looking at testing people pre and post-op from a neuropsych point of view, and really grooming and trying to explain how we can be better neurosurgeons. And this is a tool that I don't think any of us had. And I think that if there's any appeal that I personally can make to the people that took the time to have the interest to participate in this course, is that we now have a level of responsibility to kind of take this, disseminate this, learn this, excel in this, apply this, and find new applications. I truly am in awe. You've spent obviously a good portion of your career putting all of this together, and we all owe you a debt of gratitude just for what's been done up to this time.
Well, thanks, Lloyd. I think that one of the other things that I really want to get across, and it will actually address one of the questions, is that a lot of this is it's an open question. So how do we use this information? And some of the things I said are things that I've noticed or that make sense to me, but it could be wrong. We might find out that there's other things that I'm not addressing that we should be talking about. And just like skull base, right? Years ago, Roten started showing heads, and then we had to have discussions of what's the best attack angle or what's the best this or that. And we're kind of there with this, which is that there's now a tool and a methodology for systematically studying the anatomy of the cerebrum. And we can now start to have serious discussions about, well, what are the consequences of doing these things? And to touch on the base of psychiatry research, yeah, it's a major part of what we're doing. And so not necessarily Connectome, because Connectome is designed to show gross anatomy to neurosurgeons. So that's what it's approved for. It's designed for surgical planning, things like that. But if you talk about combining this with resting state fMRI and other things such as machine learning at massive scale, enterprise grade machine learning, you can really start to answer some really interesting questions. And so to just bring it up, I'll show you what I think the future looks like. And if you go into the talk, let me just share a screen here. Ultimately, psychiatry has had challenges because there wasn't a reason to have anatomy in the discussion. And so if you look back at can you guys see my screen?
Yep.
Okay. So if you go back to the original slide, one of my original slides. So obviously, we don't want to cut through the little hubs. We don't want to cut through networks. That's a challenge in of itself. But then the question is, of course, what are some of these other circuits doing? Because remember, we have a list of, well, if you have a choice, don't go through this parcellation, go through this one, right? Well, maybe it's ones that we don't know. And once you start getting into that realm, like some of the things, for example, if you go back to this, let's go to the very first trajectory we discussed, so medial frontal trajectory. So how do we know that this is the anxiosomatic region of the depressions there? We know that because of psychiatry, right? And they were the ones who found that out, and we're adopting it. And ultimately, that kind of cross-pollination is critical, that we all start talking about these issues. Because again, the evidence on this is completely clear that if you had to pick what you could do that would affect the patient's quality of life, their self-perceived quality of life, there's almost nothing you could do worse than cause depression. Almost leaving them quadriplegic. There are quadriplegics that rate their quality of life better than somebody who's horribly depressed. And so you could argue this kind of thing, but at the end of the day, what it shows is depression is no joke. It is a big deal. And the reason we've accepted this is we didn't have any idea how to avoid it. We didn't know that the Salience Network existed, let alone that it was part of this, or that Area 46 was an important part of that system, and the damage to it might cause this. Now, what does this mean, and how often is this, and is this really something that's reproducible across populations of people who gliomas? Don't know. But I think one of the things that we've been thinking about, and I'll show you one last little thing just because we have a little bit of time and it's really interesting. So this is a hypothesis that's gone around in psychiatry for a while. It's actually one of the official policies of the NIMH is to move past the DSM and move towards circuit-based understanding, research, and diagnostics. It's a framework called RDoC. And it all comes from the idea that I've come, and maybe someone else calls this too, but the transdiagnostic hypothesis, which says that if a mental illness has 3 symptoms, there are potentially 3 circuits or sets of parcellations or whatever you want to call them that drive these symptoms. So can we use machine learning to find this out? So if we take schizophrenia, there are 30 symptoms that are in the scale called the PANSS that is used to scale this. Can we link those to regions? Because if we figure out the regions, we can modulate them to change them potentially. And also it's useful for figuring out how the brain works. So in the interest of time, what we basically have built is a big hypercluster that's able to take these scans, same sort of scans, but have resting state with clinical type parameters. And we can basically process thousands of these an hour and run all sorts of different types of analyses on this. This is a pipeline that we patented and built that basically determines where in the brain are the abnormal connectivity that drives these symptoms. So what we get is a list of, for example, if we talk about hallucinations, this is in schizophrenics. These areas are the ones that the machine learning says are the most abnormal that it uses to tell the difference between schizophrenics who have hallucinations and ones who don't. And not surprisingly, auditory and visual areas are the top of the list. So makes sense. But we've done this for every symptom. And I want to show you the most interesting one, which shows us how little we know how the brain works. So machine learning, when they talk about abstract thinking, almost all of these areas, with a few exceptions, like the SMA is part of it, which is interesting by itself. But if you know what the SMA is doing, it actually makes a lot of sense. And the SMA, for example, is the target for OCD, for TMS. It's an FDA-approved target. So, but if you look at all these other ones, they're all visual areas. They're not early visual areas. They're like ventral stream and later visual areas. So why is the visual system such a part of abstract thought? And that's a great question, but the machine learning is pretty clear that it's telling us the visual system is what's abnormal in patients. So if you think about this, what this gets down to is we've basically taken a psychiatric disease and made it into an anatomic problem. And so the convergence of the two areas is pretty obvious. The more important thing is that, of course, with big scale machine learning and the kind of stuff that we're using to build Connectome, there's a lot of other things you can do with this. And this is something we're building over the next year or so and taking to the FDA, hopefully.